so far, 1.5 million deaths. So when you put that in perspective and then relate that to Australia's numbers, it really just puts into up on a pedestal how well Australia is doing in relation to controlling the virus and effectively, I think you're seeing a program of almost elimination rather than just suppression here in Australia. I realise that both of those terms come with some connotation, but from my reading, certainly on a personal side of some of the approaches, particularly by state premiers and departments at the state level, there is clearly a policy of chasing elimination rather than just strong suppression, even though I know that does vacillate a little bit at the governmental level and between governments. We're certainly seeing great progress and continued strong progress in New Zealand, and so very much like their elimination program, we're seeing this sort of creep into, I think, discussions at some of the state levels. New South Wales, I think, is a standout as slightly different and quite vocal through the Premier that their approach is containment or suppression rather than chasing full elimination. And I think that's a very interesting discussion about how those border controls will come and go over the next while. Many of you are looking at mortality rates, I'm sure, and questioning what's happening and is the virus getting weaker, etc. I must be clear that what we see early on in a pandemic is that those who are most vulnerable get affected first, and so you do see quite a relatively higher mortality rate for a period. There's also some statistical bias in that early on we are just testing a few people, and those few are often those who are most sick, and therefore we see a comparatively large mortality rate as a total. But now, as you see, 60 million people infected that we know of, and 1.4 million deaths. So the mortality rate, I think, will settle by the time we average it all out to around the 1% or so. So the virus hasn't really changed, but our knowledge of it changes over time, and the way we test and the volume of testing that's occurring is changing, and that's why you're seeing the statistics change slightly. There was discussion, it was quite interesting to watch what happened in South Australia about an incubation period that we know is around 4 to 5 days. So that means that when somebody is infected first, they will not infect others for at least between 4 and 5 days, because they take some time to develop what we call like almost a factory on how to produce the virus and shed it and send it on to others. After that point, then they start to infect others. What we saw from the Chief Health Officer in South Australia was a discussion of maybe we have a special kind of virus here. You know, the 60 million infections we've seen around the world must be slightly different than what's happening in South Australia, because we have somebody who's got infected just 1 day later after just being, they got infected and they've shared it to somebody else 1 day later. Of course, then it broke that the reason was that somebody had lied about what their second job was. And so, again, science sort of came through, and we took a big breath and said, no, it's just the same as everywhere else in the world. There is still this incubation period of 4 to 5 days. It is very important to know that at the factory level, the processing level, that there is that window and period where people who have been exposed can incubate, test negative, not be, I suppose, a threat to others until they start to shed the virus, and then they start to infect others. I think the other things that are coming through, if I step back and look at what's happening in Australia versus the rest of the world, clearly the Northern Hemisphere are going through a winter period now. And those of you who worked with us in the past and from previous presentations, we've talked about this series of peaks and troughs of waves of virus as it circulates around the world. We always knew it would be worse during this period in Europe because of the cooler weather, and not so much that this is an environmentally spread disease that requires cold weather. It just means that people's behavior changes in a colder season, and they come into more compressed living, into tighter areas, and therefore the virus jumps from one person to another during that period. And so that's where we see that change. What does that mean for Australia? Well, it means that we have the summer season coming, and of course, the more people exercise and stay outdoors, the lower the risk, which is fantastic. UV sunlight and fresh air, etc., all help decrease our risks. We may see increasing risks in February, March as the seasons start to change around the country, particularly in the south. So what I would say to everybody is we need to think now about how we can use this relatively lower risk period to prepare for what's going to come when we hit our autumn here in Australia. And that's what I would ask us all to look at that period and say simulations, exercise, training, etc. On that and the development across the country and across the world, it's still showing that contact trace and the ability to test early and then to contact trace is one of our key strategies to fight the disease. And that does worry me, again, a personal opinion, but as I read the world and the Australian context, I'm still worried by our capacity at a state level to do robust contact tracing if we were to get a large outbreak again. I think New South Wales, again, leading the way with very strong contact tracing. You've seen a lot of discussion in Victoria about lessons learned in contact tracing. I think South Australia did a good job in the last week or two with contact tracing. But if this is to get bad again and another wave comes, then at a business level, at a meat processing plant, you will have extra pressure to do a sort of an internal contact trace process for yourselves, and that has to be part of your planning. Jumping on, if I can, to vaccines. So just I don't want to put a downer on the actual numbers that are coming out, but I do want everybody to look at this with open eyes and to understand the layers of I suppose mandate and also personal or corporate interest in putting out certain numbers. And so in scientific and medical bases, usually we don't release results until we're sure that they're statistically significant. And I was a bit surprised, really, when Pfizer announced so early, well before they had reached the minimum power calculation for their particular study, they started to release the efficacy of their vaccine. And you should know behind the scenes that same CEO then personally sold about $6 million worth of his own shares in the market when the news broke about that. So just to put that in context, there are some other factors that are at play in the vaccine announcements that you're seeing. You're seeing other vaccine companies now announce similar numbers. I feel that they're painted in a corner. They can't really release any number that doesn't start with a 9 as a total percentage value. If it's not above 90%, then people are going to say, well, Pfizer and the other companies have X. Why haven't you reached the same? And so just to put it in perspective, there is an economic and a business side to some of the vaccine discussion. On the other side, there is a logistic challenge. And so some are minus 70 degrees, some are minus 20, and some are refrigerated temperature control chains or cold chains. That doesn't worry me so much in that minus 70 is actually the same cold chain we use for Ebola vaccine in West Africa and other places, and we still manage to do it there. So we can get the logistics in place if we need to. But I think we should all be cautious that the sheer volume of production compared with 7 billion population of the world will take some time to catch up. And so you'll see an initial rollout, hopefully to the vulnerable and to particularly the aged care, the aged sector, and others who will do badly if they get the disease, and to our frontline workers who are there to care for them. Then it's a question, I think, for AMPC, and other groups to discuss how could we advocate for critical sectors. So red meat and processing, I think, needs to be on there as a critical food supply issue, and can we advocate then as a group and an industry to look at early vaccination for our staff? That would be a really great discussion. So overall, be cautious about the rollout timing. I think Q2, Q3 would probably be a sensible period to start to plan. But certainly I don't believe the hype about it coming before December, etc. Certainly not in Australia or elsewhere. If it comes out, it will be for photo opportunity purposes, or perhaps a million here and there, but really not the scale that we need to get up to, which would be 60 to 70% of people who are vaccinated and have achieved immunity. On the testing side, I think there's lots of development work. And so we have here in Australia and across the world this thing called PCR, polymerase chain reaction, which is the gold standard test. It's the test that If you fly into Australia, you get given that test on day 3 and day 11, for example. It's the one that goes in your throat and nose, and then in the laboratory, it chases down and finds and amplifies so we can see it, even the tiniest fragment of virus. Okay, so that truly is the gold standard, and that's the one we measure all other forms of testing against. But as I say, it takes some time. Even on the machine, it takes 5 to 6 hours, and by the time you get the results back, on average 24, perhaps on a bad day 48 hours to wait for that test result. There is new emerging evidence, and across the world, particularly UK, US, and Europe, where they're using this thing called antigen testing. We've been involved with some of this now. We've just rolled it out in Darwin for quarantine staff. So we looked at the lessons of Victoria, and well before South Australia broke, we knew that there was an issue here, that those who are managing quarantine centres are contacting, probably our only risk of COVID in the country right now is in around these centres, and therefore we should look after those people, make sure the protocols are strong, but also look at testing them serially. So we put in place nasal swabbing, but we do it at a point of care. So these antigen tests are available within 10 minutes. They literally have a nasal swab, you mix it with some fluid, you drop that fluid on a sort of cartridge, and a bit like a pregnancy test, you get a result within 10 minutes. And then that person goes to work for that day. And we know that in the cycle of incubation, as I talked about earlier, we need to retest every twice a week, so between 3 and 4 days. And so these quarantine staff are now getting recurrently tested every 3 to 4 days, and we can be sure that those who are doing that great service for the rest of Australia by managing a quarantine centre don't have a risk of taking it home to their families or it breaking out in Darwin's vulnerable Indigenous population, etc. I would be really interested that that occurs now in all quarantine centres across the rest of the country, because right now the testing had not been happening, but when the testing comes, it should be twice weekly. Why am I saying it here in a red meat processing discussion? Well, because I really think that if another wave comes, this could be our chance to say to anybody who comes to your facility and tries to say, you've got to either decrease your staff down to 2/3 like we saw in Victoria, or we're going to shut down your production for a while, not necessarily because you have a case inside. That's more about contact tracing and making sure there's no outbreak inside your facility. But if there's community spread nearby, your protocols are still strong and robust, so you shouldn't be shut down because you have protocols. But if there is a risk of that, we could instigate sequential testing twice a week for the staff coming to work and be sure that we keep COVID out of your facility and you remain completely open. I think that's a very interesting new development. And so now with these new TGA approved antigen testing, and there's about 6 or 7 you can choose, they're all around 90% specific and 100% sensitive and 100% specific. So they miss 1 in 10, but they generally miss those who are near the end of their disease when they're least infective. And they are generally almost 100% specific, so they don't give you a false positive. Very quickly then, before I hand back to you, Amanda, and on to Jay, viruses on meat. Now, this, just so if I was to look at the current WHO website, it still says that this is not a danger, that packaging around food is not a known transmitter for COVID. And of course, food itself cannot transmit the virus, as in it doesn't replicate on the surface like meat or on vegetables, etc. Now, of course, WHO has to come out with those kind of global statements because it doesn't want to upset food supply. It doesn't want to create panic in the population. And it absolutely is correct that in general, that is not a risk. On the other side, we have to look at the evidence around viruses and how we deal with them normally in the laboratory. Now, we often freeze them. We often freeze them to study them later, and when we wake them up or we thaw them out, they are completely active. And so it is credible and scientifically provable that you could freeze a virus and wake it up and it can transmit to somebody else. Now the question comes, what is the real risk of shedding onto a outer surface of a product that you've just frozen, and then that frozen sort of droplet that you've spread onto that product going to another country and then possibly infecting somebody else. So clearly there has to be lots of protocol breaches. Somebody has to put their hands on something while it's thawing and then put their hands to their mouth or their nose and get infected. So it is rare and it's still hard to do, but you can certainly on the science side, it is possible that viruses can live on the outer surface of frozen things, and that of course has an implication, I suppose, for red meat as well. For me, so the health and science side shows it can be possible. What does that mean for Australia? Well, for us in a country that is effectively almost eliminating COVID, and certainly it has extremely low risk, this is a point of difference versus Brazil or the US or other large meat producers. Where countries are having 200,000 cases per day, like in the US, and we can say, no, in Australia, our rates of COVID are effectively zero at the moment for local transmission, and therefore we should be able to announce or launch to other countries and say meat bought from Australia is extremely these COVID times. And then finally, I want to just touch on long COVID. It is an interesting one from a work health and safety, and if we do get other waves here in Australia and people are infected, it's not just a question of do they recover quickly or do they require hospitalization, and unfortunately if they're vulnerable or in some way do they have a risk of mortality. There's also this other arm that they can travel down, which is it's in the 1 or 2% amount, but certainly in the UK, in the US and Europe, where they have very, very large numbers, they are seeing a small group who don't recover straight away, but actually have 2, 3, 4 months of chronic fatigue, vasculitis, so it affects their blood vessels, it makes them feel extremely weak and sore, they can have ongoing shortness of breath, and so that kind of package of symptoms we're calling long COVID. So it truly is, it's not just a sequelae or some sort of complication. It's as if they're continuing to suffer COVID for a lot longer than you would have expected, which is normally around 10 days or so. So just to mention that, again, it's a point of interest at the moment, thank goodness, and happening overseas. But if it was to ever get bad here in Australia, it is something we'd have to think about for those of us working in health and safety in manufacturing environments. I think that's it. So again, new developments and the overall numbers, vaccines, testing, and then that discussion on viruses on meat, and then on long COVID. Thanks, Amanda. And back to you.
Thanks, Dr. Norton. That was a very informative discussion. We're going to keep questions to the end of today's session, and Dr. Norton's going to be online till we get to the end. So please feel free to type some questions through on the meeting chat, or at the end we can use the raising your hands as well. So next I'd like to hand over to Mary Wu. Dr. Norton sort of gave a nice lead in terms of any advocacy and things like that the red meat industry possibly could do in terms of vaccinations and that. So over to you, Mary, from AMIC. Thank you.
Thanks very much, Amanda. I might just start by just addressing some of those issues that Dr. Norton presented, particularly in relation to the vaccine. My understanding is that the WHO does actually have a framework in terms of prioritization of vaccines. So under that framework, it looks at different percentages of vaccine availability. So, for example, if there was 10% vaccine available, who should be in that population be given the vaccine, compared to if there was 20% or 20 to 50%. I think there's 3 different stages of priority, and then it sort of opens up into a general framework. When I looked at the last, certainly agriculture was a stage 2 priority, and then certainly also from that was from the food security perspective. And then there was obviously the economic argument behind there as well, which the WHO captured as a value statement. And then from the meat processing sector, I think it was a stage 3. So we're captured in both stages 2 and 3. But the next obviously point is around how does the Australian government then use that WHO framework. So certainly that's where the advocacy efforts would be targeted towards, is ensuring that that framework is adopted. So now with that, I might just go into my presentation. it's only a very short, sharp presentation in relation to just a quick update of where we're at. So essentially, can you all see my screen? Yeah, so I'll just go into the presentation mode. So my presentation will just very quickly cover state restrictions, the trade update in relation to export and some of the preparedness activities that we've been doing. So in relation to state, obviously as of 9th of November, the critical issues that we've been saying in Victoria around workforce restrictions have been lifted. We're continuing to work with AMIC. We understand that a new direction has been signed off on the 22nd of November. We've got that basically ready to go to the membership. We're waiting for some briefings from AMIC at the moment just to confirm the points that are on the screen. So we understand that compulsory temperature testing, so the daily temperature testing will be removed. Additional PPE in relation to COVID will no longer be mandated. In particular, the current surveillance testing that's been undertaken in Victoria will no longer be mandated. As similarly in relation to requirements for staff working one job, as well as a high-risk COVID plan. That being said, there will be a number of elements that will continue to be retained, including the need for a COVID-safe plan. We're still confirming in relation to face coverings. It is a little bit unclear in the directive how that's phrased as to whether they will still be required. The need for COVID marshals will remain, as well as nightly comprehensive cleaning and the use of workforce bubbles. As we understand, obviously there's been quite a few state border changes in the last few days. They're coming in thick and fast, and we've seen obviously that Queensland New South Wales border will be open on 1 December. And obviously the South Australia situation is that that's improved as well. So we'll continue hopefully to see that the borders will continue to open prior to Christmas. Now the next slide is in relation to trade updates. Obviously there's been significant disruptions to flight schedules as a result of COVID. We've seen most of that being impacted, particularly in relation to sheep meat to the MENA region. Specifically around chilled lamb carcass trade, but overall there has been a significant decline in the amount of air freight going out. We've also seen that some markets have switched over to sea freight where possible, particularly for around the retail channels, not so much the food services channels. Obviously, there's been significant usage of IFAM, and we've obviously advocated for that to be extended, and now that's going to take until mid-2021. Now, in relation to China, obviously we've still got, in Australia, there's still the 2 plants that are suspended because of COVID. Globally, there's many dozens of establishments currently either self-suspended or suspended by GAC. And there's the pace of establishment relistings or desuspensions is probably not that high at this stage, with mixed successes between various countries. Over the past month, there has been apparently at least 15 batches reported of imported cold products from Brazil, New Zealand, Argentina that have tested positive on PCR in market. Certainly, we would have seen overnight that the latest is the Pudong airport in Shanghai has now temporarily been disrupted again in relation to following a string of detections in cargo handlers. So we understand that all the cargo going into Pudong has been diverted as of today. Furthermore, there's also port disruptions in ports like Tianjin, which resulted in diversions to other ports. And we continue to get reports that basically China has tightened regulations on a lot of the provinces and cities in relation to cold chain and have additional mandated requirements around traceability. So to date, most of these have been all in market requirements, and we've seen certainly new technical guidelines that have been issued in relation to prevention, control, as well as disinfection of COVID. which we've seen being implemented at multiple steps within the market. So, the final slide's in relation to the preparedness activities that AMIC has been undertaking. So certainly you might have seen that I've put in here a couple of different guidelines that we've developed in line with other state authorities. So for example, the food PIRSA has published the COVID-19 in your workplace guideline, and we understand Safe Food Queensland has also published a response protocol for red meat processing establishments. New South Wales Food Authority, we participated in a number of webinars with them, and in addition to that, there has been, you can go to their website to find their latest guideline. Similarly, obviously, we've been working very closely with AgFit as well as the Commonwealth Department of Agriculture in relation to ongoing management and responses. So that's it from me.
Thanks very much, Mary. It was great to have AMIC on board today to be able to give an industry update, so we appreciate you taking the time. Mary's going to be online with us till the end as well to be able to answer any industry related questions. Next, we're going to move into what AMPC are doing in terms of our project space. So we've got Matt O'Brien and myself will present on a number of projects that we're doing, looking at sort of shorter and longer term COVID and business sort of continuity PIPs. So I will just put up our presentation and hopefully you will be able to see that coming through. Right, well, I'll hand over to Matt O'Brien, who is one of our core program managers, to run through the first couple of projects that he's been working up with Respond Global. Thanks, Matt.
Yeah, thanks, Amanda. While the screen's loading up, I'd also reiterate thanking Mary and Ian for taking the time out of their busy schedules to actually be able to work with us to bring this round table to you today. And it's really great that we're all working together to try and work on a common enemy, I suppose, if we call the virus that. Amanda, I cannot see my slides at this point, so I'll just have to fly a little bit. Are you still sharing them?
Matt, we're just having some technical issues in the AMPC boardroom, but
it was there, Amanda.
Okay, if you want to start, Matt, and I'll continue to work to get them back up.
Okay, so we're working in a number of areas for the industry. One of the first ones was that obviously there's been, as mentioned by Mary, that in Victoria there's still a requirement for us to be having a COVID marshal, and it was the process is actually going through the healthcare system or the Department of Health to get the COVID marshal qualification. I was approached by AMIC to do some work to try and see if we could get a meat industry focused COVID marshal project, which we've got underway. The first milestone has been delivered to me yesterday, and we should have the finalisation of the project for a short training module for COVID marshal that is applicable to the meat industry, available by the end of December. So that's a really good outcome for us to be able to provide you with something that's more related to yourself rather than aged care or hospital from a COVID marshal perspective. The next project that we're working on is an infectious disease management plan. That one is so the first one was Response Consulting was providing that the work for that project. Respond Global, who Dr Ian Norton is a part of, working on the next two projects that I'm going to present. The first one is this infectious disease management plan, which is the development of a business continuity plan for the red meat supply chain, and we're actually going to be working with one of our members to actually work this up and to try and put this, as a first example of a business continuity plan for infectious diseases, whether they be viral, bacterial, protozoal, protozoan. So and that's not just for the processing, it's up and down the supply chain, so the what ifs, the management and mitigation. And we're wanting to put that in such a modular manner such that other business continuity issues that may arise, whether it be bushfires or other sorts of issues, can be dealt with and put into a business continuity plan, because we all know that with this outbreak, it's going to ensure that auditors and certainly customers are going to be wanting to understand how our industry can maintain their business continuity. So that's the next one. It is currently sitting with matching funding with MLA, awaiting that. So hopefully in the next day or so that we'll have that ready for contracting. And the final project that I'm working on is that once we do put together how we actually put in a business continuity plan, we actually want to share that with industry. So what we're putting together is a business continuity training package in order to ensure that the things that we've learned, that we learn along the way in putting together a business continuity plan for dealing with infectious diseases, that we can put that together in a training package so that you don't have to make any of the mistakes that we make within this first initial working up of it. And we hopefully, if we can get approval for it, we'd like to include it into potentially the Certificate 3 or the Certificate 4 in order so that we can understand how to A, build one, B, how to audit it, C, how to manage it, and how to test it. So that one is sitting also awaiting matching funding from MLA so that we can ensure that we get into contracting and get stuck into that one as soon as possible. Amanda, I'll hand it over to yourself now. Unfortunately, I didn't get my slides up, but that's okay. I'll hand over to yourself and you can talk about the next couple of projects that we've got that AMPC are working on.
Thanks, Matt, and sorry for the technical issues. So AMPC have been working with industry and Respond Global, and we've created a syndicated PIP. And the reason we've created a syndicated PIP is to be able to speed up the process. Obviously, with COVID rapidly changing and the environment that our processes are working in, we've put in an application which has been approved. So any members that want to do a COVID-related PIP now, if you can get in contact with myself or Matt, we will be able to help set that up. So some examples of things that you may want to do is be able to get a company like the Respond Global to be able to come in and actually do an audit of your policies and procedures at the moment, be able to provide extra training or resources to help manage and upskill your staff. So it is quite flexible, and it's designed, the way we've written the syndicated PIP is so that it can be customised to each individual plant to what your needs are. So it's not one hard and fast project that you need to do. It can be very flexible and fluid, and we'd love to be able to talk to you about, what your needs might be. And it can also be looking at not only the current COVID situation, but what's that longer term business continuity, using such things as traffic light systems to, if, let's say, another wave comes through or a different pandemic, heaven help us that will, hopefully that doesn't happen. But, the environment that we're working in is just rapidly changing. So we do have that flexibility here at the moment. So please feel free to have some further discussions with Matt, myself, or any of the other co-innovation managers. So we've got Blair over in WA for our WA people that are on now. We've got Sean Starling and David Dwyer, who looks after Northern New South Wales and into Queensland. We've got Murray Miller, who is based in Victoria, and myself in Southern New South Wales and the edge of Victoria as well. So please feel free to contact us. But I might hand over to Ian now just to talk about some of the, potential things that can be put into the pit, because we have worked up a couple of different processes at the moment with Respond Global. So, Ian, would you like to just add anything to that?
Well, yeah, thanks, Amanda, and thanks, Matt. I suppose just to add that each facility, each company, and each group are different, and if you have several plants, they're all slightly different. So I think it's really having the tools, but then adapting them to local context. That's really what we've learned in helping several groups now already in the red meat industry. It's also a challenge for you, especially if you work in multiple different jurisdictions, because each of your state health departments have a different perspective. It is still one virus and it's still one country, but they do have a different flavor, different personnel at the local level and at the state level. And so it is really important in getting them on board. That's probably our biggest lesson so far, is that as well as strong protocols and helping you who know your business best of all we do is help you with that extra 3 or 5% to get you over the final line. But then to talk to your local groups, have us sort of advocate and not have the two groups talking past each other. Sometimes public health just talks straight past business, and we're trying to align that and say, okay, we can translate for both sides. We know what it's like to be in the shoes of one and the other. Let's meet in the middle. And then let's look at how we can practically implement those core pillars, because there's a lot of, I suppose, noise out there, but in distraction. In a way, if we can say there are 4 or 5 major things that actually stop COVID being transmitted, and these are the things we prioritize. I think that simulation and desktop approach is really valuable as well, and so we've done several of those. I think there's a couple of groups who we work with online as well, if they want to make any comments. But certainly having a bespoke, if you like, plan per site and interacting directly with the local Ministry of Health, Department of Health, and making them feel that you guys have such strong protocols for food safety that they're probably unaware of, or a different part of the department deal with that. They don't realize you're very heavily regulated already. You have really strong protocols in place. And then just adding a little bit extra for COVID means that you're well entrenched. And I really like the idea of this approach, where this is a legacy for into the next infectious disease risk, even if it's seasonal flu or an outbreak somewhere locally. All of that is part of that business continuity plan for infectious disease.
Thanks, Ian. So yes, feel free, get in contact with us, talk to Respond Global as well, to talk about what your needs are, and would love to be able to work with the members to be able to support you the best we possibly can. The other project that we've got that's currently being put through the AMP system for approval, so it's not approved yet, I'll call that one out, but we're looking at creating some videos and infographics for industry, so an industry-wide one that you'll be able to use to help upskill and inform your workforces from induction through to your supervisors. So that's something that we're currently working on, some infographics that you'll be able to put up in lunchrooms and things like that, just as that reminder, because, as we've heard today, it's not going to go away overnight, and we'll just need those constant reminders. So that's another project that AMPC is working on. So that wraps up the formal section of today. I can see that there's lots of questions starting to come through, which is fantastic. So I might hand over to Jay from Aegis Insurance to help facilitate the next section. Thanks, Jay.
Thanks, Amanda. Thanks, everyone. It's been really interesting so far, and I was just sort of trying to work out how best we're going to ask these questions. But Andrew's asked Matt, one for you first up. Really questions around is there a timeline around your business continuity plan templates and the rolling out of those packages?
Yeah, Jay. Look, we're because we're in. It's taken a bit of time to get the contracting right. We're probably looking around middle of the year to have that project completed. In that time, we're hoping to be able to run it through the appropriate, I suppose, skills boards to ensure that once we do have this completed, that it's able to be rolled out relatively rapidly. Now, we've been at pains to ensure that we've gone beyond the level of just COVID, because we do know, I mean, before COVID, no one thought of, we potentially did think about, I suppose, human transmitted diseases, but we didn't really have it as high as a priority. So we probably had emergency animal diseases as a higher priority. So therefore, this one is, we're sort of a bit behind the 8 ball on this one, and trying to get this one through as quickly as we can.
Thank you for that. I hope that answers that question. Ian, obviously there are a number of questions that are going to get directed to you, and I'm fairly comfortable that you expected that. There are a lot of them around the issues. We're seeing a lot of questions here around the issues with vaccines and the like. And some of the questions that you may or may not be able to answer at the moment are around whether those previous positive, those people that have previously tested positive and have recovered, whether they'll need the vaccine, and whether the vaccine, given that we've got a potentially mutating virus, whether it's going to cover all, or whether it becomes an issue for the flu type vaccines into the future. Yeah. What can you tell us on that?
Well, they're great questions. Some of this we just don't know as a global community yet. So what the first question is on, if you got the virus, you went through the disease, you get what we call natural immunity. What we don't know yet is how long that natural immunity lasts for, and that's a key. It's still a very new virus. It's only been around for 10 or 11 months. Therefore, we don't know longer term how long somebody who was exposed would be immune. If it is one of those diseases that gives you lifelong immunity, then that's great, and therefore we can recommend no vaccine. At the moment, we don't know that, so I think the safest option would be to offer a vaccine. We don't know of any cross-reaction or negative impact on somebody if they've had the disease and then you give them the vaccine, so that's a good thing. What we do expect, and a great question on the mutation side, one other thing on the other, there is slightly increasing evidence now that there are people who are getting a second round of COVID. That anecdotal still, small numbers, but that shows us that not everybody's the same. Were they immunocompromised and they just didn't react in the same way and develop immunity and antibodies? We don't know, but the science will emerge more on that. And I know that global bodies like CDC, WHO won't give us a finite answer on that yet. The second one on mutations, though, that's fascinating. Absolutely, the virus mutates. We're really worried it could mutate and become much more virulent, and we could see a second or third wave that comes with a slightly different strain and it's much more aggressive. And that same thing can also mean that occasionally, if it changes the proteins, especially around that spike protein you've probably all heard about, means that it could become resistant to a vaccine that we've already tried, because it was there generating a specific protein. And if virus changes in a mutation, that protein and hides it, then your body can't recognize it because it's looking for that particular protein. And if the virus has mutated and hidden it, we won't know. What is good about this is that across the world there are multiple different types of vaccine in production. There's over 200 candidates, maybe 30 front runners, and at least 6 to 10 or so in very late stage, third stage trials. And several of them work in completely novel ways. Particularly the Pfizer and Moderna vaccines are using a very novel technology where we inject mRNA, so it's a little code that gets you in your body to actually produce protein that you then develop antibodies against, and that protein happens to be from that virus. So that's an angle to attack the virus. There are other proteins, other viruses, or vaccines rather, that are developed to take different parts of the same virus at different proteins. And so if we lose one or two vaccines because of a mutation, we should have several others that can be used and still be effective. So all that tells us is it's good news that I think we're getting good viruses and vaccines in the future. I will put right now the proviso that I'm sure it will be a double dose, so you'll need a first shot and then a second booster, and we may well see a round of vaccines that require boosters every year or two.
Thanks, Ian. Mary, you had a question?
Yeah, I've got a couple of questions. So Dr. Norton, one of the stuff that you just talked about is an mRNA vaccine as opposed to a traditional protein-based vaccine. I think initially in your presentation you talked about there being different sort of storage and transport requirements. Is it? I think the mRNA is a much easier one to transport, isn't it?
It's the other way around, Mary. Actually, the mRNA ones are the super cold ones.
Oh, right. Okay. So it's actually harder to transport.
It is. It's going to be tough for the bush to get. Yeah, it needs liquid nitrogen to carry in these Arctech special eskies, effectively. Yeah.
Okay. Thank you. My second question was in relation to you talked about the antigen testing initially. I had understood that the Communicable Disease Network in Australia and the Public Health Lab Network have recommended that antigen testing isn't appropriate where there's low prevalence of the virus. So because of the risk of false negatives, like when you said, one in 10, and I think they basically said if the risk is too great, like for example, in our plants, if we miss one and the one worker comes in with the virus, and the risk of that going through the plant and the impact on establishment operation, that it will be more widely adopted by health units all around because of that risk.
So that's certainly been talked about. So this idea of a positive predictive value. So if you take 1 million people and it's very low prevalence, then you're dealing with small numbers. Now you could take another approach and say, if the prevalence is the prevalence, say it's 95 people in 1 million, then the amount you pick up is still the same amount you pick up. You still pick up 9 out of 10 of those 95 people who had the disease if the test is working. I think the thing that they were driving against was very high numbers of false positives. So that in a very low prevalence disease is interesting. If you have 1 million people and there's hardly any disease in those millions of people, but you've got a test that 0.5% of the time tells you you've got it when you don't have it, then that's a bit of a pain. That could be 50,000 people in a large group. What's good about these new antigen tests are that they're coming as close to 100% as we get in medicine, and therefore that chance is very, very low, especially on the new version. So back in April, May, when they tried to start these tests, they weren't strong. Now they're much, much better, and they're coming up to some of the new ones 95% sensitive and 100% specific. So that argument is starting to fade. There's a really good paper out from Harvard. It was published just 3-4 days ago, and it shows at another population level, particularly the US, it's better to do a test twice a week that has low sensitivity versus one test that takes 48 hours to come back and is only available every week or two. That over a population is far, far better than population. In fact, you could get rid of, they show an outbreak like New York had, you can get rid of that outbreak in 6 weeks if you were to use these antigen tests in the right way. So I think that's finally where it will come through. There is some other vested interest in the market here in Australia. The laboratories quite like the PCR. So on the monetary value, they get $100 rebate right now, whereas they don't get any rebate for the antigen testing. So all of those things factor. These antigen tests are 1/5 the cost of a PCR. So there are other things at play, but I hope the Doherty Institute studies that are looking at the new TGA approved antigen testing will come out soon, and it will show that we have a local test as well as the studies that were done overseas.
Yeah, so certainly from the meat processing perspective, it'd be very handy to have a rapid test that can be conducted on site. And if it's a cheaper tests as well to run. I think there were some issues around ethical or privacy concerns, and who administers it, how are the results interpreted, all that sort of stuff that will need to be worked through prior to it being further used within the industry. But I think certainly if we can address that risk of that false negative that I talked about, I think it'd be quite useful.
Yeah, no, fully agree, Marianne. That's sort of part of the work we've been doing for some of the groups on business continuity planning and on-site. In a way, it gives them an added control that can be added at a certain risk point,
Yeah.
and that puts the power or the sort of the ownership back on the facility, which is nice. It's just more empowering if you have another test you can put in place that stops you being shut down. Yeah.
Yeah, sure. My third question was in relation to your point around the potential for the virus to be present on frozen products. Certainly, I know that the international consensus is that there is very little or negligible risk of that occurring, and certainly the science to date, I think, has been quite limited in terms of being able to study it in a commercial environment. Certainly dosage related and infectivity related. So can you maybe provide a little bit more information of the scientific context if there's been any recent developments in that area?
Yeah, it's hard, isn't it? Because there's a political overlay here. There's a trade agreement overlay from the Chinese side. Certainly from the science side, China CDC is very strong. I've worked for many years while in WHO and going to visit them, and they certainly, when the science comes out, it's robust. But you're true. You're correct. If they'd gone out to a sample site and then just taken a swab of a particular product, what is the actual transmissibility in real sense to local persons? They're already wearing PPE. It's extreme. It's negligible, really. And so I think all the evidence will be mainly anecdotal right now. There's no new change on that. I think if we were to actually physically try and get a COVID person or a positive sample in our hand and put it onto a product, freeze it, and then study it later, that would be interesting to do. I just wish that some labs would start to think about it in that way. Instead, what we're seeing is it's being used as a tool to change trade practice, and that's not very healthy, and it's certainly not scientific. That's not what we want to support. So, as I said, for a virus and survival in freezing, that's so well known. Of course, all the research labs around the world freeze viruses all the time. In fact, as I've said, sort of jokingly, smallpox is alive and well in a couple of countries around the world, deeply frozen. We had a big panic actually in WHO when one of those labs in Russia that stores that particular virus had a huge fire, and we were worried it was going to escape because it would be absolutely able to transmit across the world again. So I think New Zealand is an interesting one. I am avidly trying to watch the research on that one and their outbreak in the frozen meat or the frozen food handler, because they don't really have a strong case for any other source right now as well. And at the time they were sort of quoting the older WHO sort of statement that's saying it's just not possible, but science shows us that it is possible notionally. It's just a question of whether it's likely because of the way people act around that food, and they literally will have to touch it, then put their hands to their mouth. And if we can prevent that, then you prevent the jump into the human.
Thank you.
Steve, I'll hand over to you. You've got a question there.
Good afternoon, everyone. I'm Steve Burton. I'm the Group Health and Safety Manager at Australian Country Choice here in Cannon Hill. For those that don't know, we operate a red meat processing plant. We have 1,200 people on site, and we've partnered with Dr Norton's company, Respond Global, over the last several months. And one of the key things that's, not that it was a secondary point, but certainly in conjunction with the way that we approached our distancing, we really looked at, because given the setup of the processing plant, specifically around conveyors and the way the lines work, they are actually designed for people to stand almost shoulder to shoulder to allow for efficient processing methodologies. We were fortunate enough where, through better design, we had a shutdown in late 2019, which allowed us to expand the distance in key areas with personnel. But we took that a number of steps further, and this is getting back to the point of whether or not it's reasonable to expect that the virus can be transferred onto product and then frozen and then transported. to Dr. Norton's comment earlier, we went through a series of RPE, so just respiratory face and balaclava scenarios. We started off with a basic surgical mask. We went to a polyester cotton blend balaclava, and ultimately we ended up with our own design based on Respond Global's recommendations, and the technical specifications of these we're quite happy to hand out. They're now freely available in the market. Those balaclavas are mandatory on the site when you're in an operational area. When you combine that with the effective social distancing, a number of other sanitisation, hygiene, and all the other protocols that are in place, I would agree with Dr. Norton in that the chance of transmission onto that product is nominal. They have gloves on, they have full face balaclavas on, they have face shields on. It would be really, really quite difficult. And I understand because there was a lot of talk initially about the transmission, you might recall, from the Cedar Meats outbreak, because that was specifically talking about the interaction between the workforce and the product itself. But again, the work that we've done with Respond Global, and I think earlier the comment was made, things like the traffic light system, we had things well progressed in our business, and it was that, again, to Dr. Ian Norton's point, we had that 5% where we didn't know what we didn't know. It was that simple. We may be a food processing plant, and yes, we have high hygiene standards, food safety standards, which again, the point was made earlier that both Queensland Health and the public health units really did not understand the level of application, and more importantly, where that's cross purpose, the cross effectiveness. The bulk of what food safety is about hygiene. It's about process and it's about control. So I can certainly attest to the fact that I'm sitting here at Cannon Hill now quite comfortable in the fact that we process 300,000 head a year plus. And I'm quite comfortable that we have an absolutely nominal chance of our product going out the door with any type of contaminant. Our protocols, again, they start at the gatehouse. You're temperature tested. It's just this morning I ran the most recent test that since the 21st of March, we've had temp testing in place, and we're up to 216,000 tests. We had 4 of those that were over 37.5. We sent 163 off for testing, and all 163 came back negative. So I just wanted to sort of reinforce the idea, because I know that there's certainly non-scientific information in the market. They're talking about the viruses being on product. Yes, it can be transferred because, as Ian said earlier, a virus can be stored or frozen. I get that. But if you come back to the preventative space, the proactive behaviour space, you can actively display that you are monitoring, that you're reviewing, that you are testing these things. It is absolutely negligible, the exposed risk.
Thanks, Steve, and thanks for your testimony with the work that you've been doing with Respond Global, having sat on some of the meetings that you've been having with them and AMPC around working up the sort of COVID PIPs and things like that. It's been great to see you've been so proactive in that space. So if anybody is interested, as we said before, get in touch with Respond Global or ourselves, and we can help facilitate that. And I'm more than happy, I'm sure there'll be some other plants that would be able to talk to you on a one-on-one basis too, if you like. The next question probably is directed at you, Ian. Is there any kind of prerequisite for testing labs to do PCR testing on plants? If a lab is using PCR methods to test pathogens, would it be enough?
Okay, so I'm correct me if I'm wrong, Abby, but is the question, could you do PCR testing within your own lab on site? Then the answer would be no, you wouldn't be allowed to run your own tests if that's if that's your question, it would have to go through, if you're going to use PCR, it must be in an accredited Australian sort of human lab, as it were, and there are either public and private labs who have that endorsement. The reason being because it is a potentially hazardous fluid coming out of people's noses if there's any chance that they're COVID positive, and of course that has to be managed in a specific way. The PCR machine testing, no. If you want to ask about the science behind the machines, no, that it's relatively simple. You get there's multiple product machines out there can handle this. You just have to get the right reagents and the right cartridges for your particular test machine. But as I say, you won't be allowed to do that on site unless you're an accredited lab able to do COVID. The difference, and Mary brought this up very well, that the point of care testing, which means the cartridges for antigen, now that can be done in your workplace. It can be done in the car park, in tents, whatever. You just need, I would absolutely endorse what Mary was saying, though. It has to be with a credible medical group. TGA say it can only be used by medical registered practitioners, so doctors and nurses, and they absolutely need to be doing the right quality assurance on those test kits before they start that morning's process. They need to be gathering the data in the right way. They need to be getting rid of the swabs in a proper biohazard way as well. So yeah, you won't be able to just buy the kits yourself and do them. You'll need to work with a group who can do that for you.
Yeah. The reason this question is raised is now we have platforms which can do COVID test also along with these pathogens. The platforms what we use, they are able to handle COVID testing. As you mentioned, TGA, if we don't have approval from TGA or similar kind, we are unable to test for human pathogens. Would that be a straightforward no answer?
Yes, I believe so. No, but Abby, I would talk to your local health department and the lab guys. Which state are you working in?
We are in Victoria, and our lab is not accredited and a PC2 category.
Yeah, so PC3 for the PCRs generally, but anyway, I'm happy to discuss further offline if you need to as well.
Thank you.
Thanks for that. And I think that's one of those important things, Ian, that that everyone needs to get an understanding of what we can do and the like. One of the really interesting things as part of this process, is when we look back through, when we look at some of the the injury prevention and the workers' comp management issues that have come from all of this, we see that nationally there's been 500 odd accepted workers' compensation claims in Australia for COVID related issues. But 35% of those, or a third of them, have all been related to mental injuries as a consequence of being worried about getting COVID. Right, so it's not just simply the issues of the virus, but it is the fear of the pandemic. So with that in mind, one, that's a thing that everybody within the industry and all industry needs to consider. But are there three things that you would see as being those three go-to things that are obvious measures that allow our people a level of comfort that we are doing all we can to make sure that we're looking after them? Are there three go-to items or five?
Let me think of three just off the top of my head. First of all, I think number one is information is power. So if you empower your people with the right information and you make things simple for them, they feel more confident, and they feel more confident in coming back to work. The next is, I suppose, it's got to be culturally specific, and working with, for example, Steve and guys down in Greenham's and Herd and others, knowing your workforce, knowing which countries they come from, which language they prefer to speak, and using platforms that they communicate on. So using WeChat or WhatsApp or whatever the thing is that they like. Some are visual thinkers, some are like pictures, some like videos, some like to have discussions and chances to talk. Those toolbox discussions are harder to do, of course, in the COVID times, but is there a way you can do that almost virtually? So allowing that discussion. And what we're finding across the board in different industries, people feel more confident if they can see a process, it's very well articulated and they've got information about it, but they see everybody else go through it. So especially for those worried guys who are worried about catching it and their mental health is suffering because of it, if they see that everybody's going through the same thing and you are looking after making sure the guys who don't really think COVID is a big deal are still being tested surveyed every day, they feel more confident to come to work because they are worried about it. There's always a spectrum of deniers and guys who want to stay at home all the time, and the answer is sort of in the middle, because COVID is real and it's serious, but it doesn't mean we've got to stop living. We've got to live with it. And then finally, I suppose, with the testing side, the thing in South Australia that I saw was a lot of worried well. We call them the worried well. So people who are clearly, they were doing the right thing and they were stepping forward for testing, but then queuing for 11, 12 hours. I think for me, if I was to give surety to my staff working in one of the facilities, it would be to be very clear on what the response will be like and having your information products ready to go. Because if you had to shut down because of a suspect case or whatever, not trying to make up your messaging to your population then, but to have that pre-done is so important, and that gives so much confidence to them to come back to work, hopefully the next day or in 2 weeks' time, whatever the scenario is. But really thinking about, I love the idea, and thanks for bringing it up. That mental health side is so important. Yeah.
Amanda, that's probably all the questions that we have at the moment. So it's back to you to drive.
Fantastic. And just on that worry well, there was actually a really good article that I listened to on the ABC radio this morning. It was on about 6:30. If anyone wants to try and find it, it was talking about the worry wells and COVID, and it was just a really simple step process of, how to help support them. So I thought it was a good article there as well. So if you want to look at that. I'd just like to thank all the presenters today. This has been a little bit of a different format. It's been good. It's been very interactive, and hope that everyone got some value out of it. It has been recorded, so we will send it out to everyone that registered today. Feel free to share it amongst your supervisors, your production managers, etc., because I understand, they often can't get out at this period of time. So, they might want some light afternoon TV watching or something. So feel free to use it as a training resource. So once again, a big thank you to Dr. Ian Norton, Dr. Mary Wu from AMIC, and Jay for helping to facilitate today, as well as Matt and for being able to give an update on the AMPC projects. We will try and continue to do these updates, on a regular basis, just to make sure that we're communicating as much as we can with the membership, and please feel free to get in contact with anyone that's presented today. So thanks very much. We'll speak to you soon.
Can I also say, Amanda, before people go, that they can use, if there are any questions around those safety aspects, they can use the hotline as well. Absolutely. So that, there is the safety and the injury management hotline through AMPC. So certainly feel free, and we can assist to deal with any of those issues as we go.
Yep, and further to that, so if it's workers' comp related or injury management related, it will go through to Aegis Insurance, and if it's more a HR/IR issue, it will actually be then directed through to AMIC. So Aegis are running it on behalf of AMPC as a project that we're trialling for 12 months. So if you've got any work-related matter that you just want a second opinion on, please feel free to use it. It's open for all AMPC members. So thanks very much, and have a great afternoon, everyone.
Thanks, everyone.
Thanks, everyone.